Good morning. Today I am going to talk to you, medical students and paramedical students, and all those people who are associated with the patient care and, say, mainly, particularly with the clinical aspects of the problems of the patients. Last time I talked to you about acute appendicitis, etiology, pathology, and a part of the clinical features. Clinical features means the symptoms and signs. Symptom means what patient says. When we ask him what is the problem and he says that I've got pain, that is a symptom. And sign means that when we examine the patient, we elicit by our hands, palpate him, touch him, and then elicit the clinical response of the patient. That is called sign. So last time I was talking to you that appendix is a tubular structure which may be of any length, say up to 20-24 centimeters, even for 4 to 5 centimeters onwards. In between that, these are the individual experiences and studies. It's a luminal structure. It has got argenta vein cells. It is mucosa. It has the columnar epithelial cells. It is covered by serosa and, of course, supplied by the appendicular artery, which is one of the ileocholic artery. I also told you last time various causes and etiology, how appendicitis can affect infants, children, young adults, elderly, and how it can present. The presentation of appendicitis, I told you last time, depends upon the location of the appendix. The appendix may be located in a retrocecal position, say 67 to 75% cases, retrocecal, behind the cecal. It may be in the pre-ileal position, in front of the ileum, post-ileal, behind the ileum, pelvic position, subcecal and paracecal. All right. And I also told you last time that a person with acute appendicitis will have vague periumbilical pain in the abdomen, which migrates to right iliac fossa. And there's a tenderness at McBurney's point. The McBurney's point I told you last time was a line which is drawn from the iliacus to the anterior superior spine and divide this line into 3 equal parts. The junction of outer third of this line from iliacus to anterior iliac spine, the junction of outer third and the middle 2/3 is called McBurney's point. And a person who has got appendicitis, once it is inflamed, serosa is inflamed, it touches the parietal peritoneum, patient coughs, he evokes a response, they got a pain. That is called the free sign. I also told you last time that once the patient's pain migrates to right iliac fossa, right lower quadrant, there is a tenderness at McBurney's point. At this point in right lower quadrant, there is a pain, there is a tenderness. And similar type of pain can happen in a person who has got stone in the lower part of the ureter. You be careful. Don't confuse right ureteric pain with acute appendicitis. So therefore, what I wanted to tell you last time was that to diagnose appendix, much more than the investigation, we rely on the history of the patient and the clinical examination. The history. So the person with acute appendicitis comes to a late stage when there is a generalized peritonitis. It has perforated. The contents have gone into the peritoneal cavity. The picture gets confused. Then you don't know what is a perforated appendix or a peritonitis due to acute appendicitis, or it is a perforated duodenal ulcer in which the content is spread all over the peritoneal cavity. There is a chemical reaction initially, and subsequently there is a bacterial infection. The picture becomes, the abdomen becomes guarded, rigid, tenderness all over, rebound tenderness all over. Rebound tenderness means when you press the abdomen, palpate the abdomen, when you release your hand, the patient gets pain. So therefore, the picture becomes confusing. Always rely on the initial notes of a doctor who has seen the patient with acute appendicitis. The first impression, the first imagination, the first observation of human beings is correct by and large. In other aspects also, sun comes. Somebody must have thought the sun is shining. What it could be. So in that pristine glory of thought, the first impression of human beings about nature is probably much better. You can appreciate it better. Leaving aside the scientific revelation, distance, and all those things, that is different. Anyway, coming back to acute appendicitis, always rely, if you're seeing a patient in a late stage, he's not able to give you a good history, always depend upon the notes, clinical notes by the doctor or a GP who has made the first observation. The second point I wanted to tell you, last time also I discussed that your signs in acute appendicitis depend upon the location of the appendix. Now, if the person is having retrocecal appendix, the appendix is lying behind the cecum, the patient will not have that typical tenderness in the right iliac fossa. He will have a pain at the back. And since cecum is lying in front of the inflamed appendix, so patient, this gas in the cecum will not permit tenderness to be elicited properly. The patient will have some kind of urinary symptoms also in case the appendix is in pelvic position and touching the bladder. I told you last time. Or it might be touching the rectum. The person will have irritating symptoms. He may have something like, feeling of passage of loose motions. Similarly, if the appendix is located in subcecal position, the pain will be lower down. And if the appendicitis occurs in a woman who is pregnant and duration of uterus is enlarged, the appendix will be pushed upward. With the enlarged uterus, the appendix will be pushed upward. So that typical pain of appendicitis in right iliac fossa or right lower quadrant may not be there, and patient may have pain higher up. I also told you that if there is a situs inversus, the malrotation of the gut and the appendix is located on the left side, the patient will have pain on the left side. So therefore, all these possibilities should be kept in mind. Now, as far as the typical appendicitis is concerned, the next sign I want to tell you is the Ropsing sign. That means once the inflamed seroja, inflamed appendix has touched the parietal peritoneum, the right iliac fossa, and you press the abdomen, you palpate the abdomen deep in the left iliac fossa, the gut, the cecal gas or distended loops, or the loops shift the inflamed appendix, which might touch the parietal peritoneum right lower quadrant. So you press on the left side, the patient gets pain in the right lower quadrant. This is called Ropsing sign. Another sign is Scope-Swartz test. Swartz test, P-S-O-A-S, Swartz test. A person who has got retrocecal appendicitis, generally it is the most common position. In that position, you see the hip will be flexed. The attitude of a patient will be that his hip is flexed. And if you flex the knee and the hip and do, thereafter, what you do is if you extend the hip joint, the inflamed appendix touches the psoas muscle and patient gets pain. All right. Similarly, there is another test which is called Obturator test. Obturator test means that you flex the knee and the hip, obviously on the right side, and you rotate internally, the patient will have pain. This is called Obturator test. Coming back to acute appendicitis, I told you that for God's sake, keep in mind the differential diagnosis of acute appendicitis. And one of the differential diagnoses you must keep in mind in women is tubal pregnancy, ectopic gestation. All right. And in those cases, we have to do urinary HCG studies and things like that. One has to be very careful. Now, briefly, I want to tell you something, that there is a scoring system which is called Mentrels. Can you note it down? I have already put it in this thing also, YouTube also, and advanced it to students, forward to students. Mentrels. This is called Alvarado score, ALVA RADO, Alvarado score, is specifically designed to diagnose and establish the diagnosis of acute appendicitis. This is a correlation of certain features which includes symptoms, signs, and investigation. All three things are combined. So there's a foolproof method almost practically. In Mantrels, Mantrels, each of these letters stands for something about acute appendicitis, where is the absent or present, things like that. I'll tell you just now. This is called Alvarado score. What is it called? Alvarado, Alvarado score. The scoring system, the total number we allot in this scoring system are 10. 10. It will tell you whether to go ahead with surgery or shall we not. Because you see that if you do operate on a person and subsequently find he has got ureteric stone, we had it. The patient had it, you imagine what kind of a damage we are inflicting upon a patient. Similarly, if you operate on a person and you find negative laparotomy, appendix is normal, again we had it. So therefore, kindly keep all those possibilities in mind, and this Alvarado score is going to help you. So, Alvarado scores, there are certain symptoms, there are certain signs, there are certain investigations. Now let us start with Mantrels. Mental, first of all, is M. M stands for a pain which has migrated from periumbilical region to right lower quadrant. If this happens, if this is the history, if this is the story, please make a chart and allot 1 point to the patient, 1 point to a person who has pain around the umbilicus. And this pain, he says, sir, yesterday it was here in the periumbilical region and then umbilical here, and now it has shifted to the right side, right lower abdomen. Right? Allot him 1 point. Next comes A. Almost all cases of acute appendicitis, they lose their appetite. Anorexia. Lose their appetite. He doesn't feel like, eating. A. If that be so, kindly allot him 1 mark. All right. Next comes N. N stands for nausea and vomiting. What did I say? N stands for nausea and vomiting. If a person has got nausea and vomiting after the onset of the pain, allot him 1 point. But if a person has got nausea and vomiting before the pain started, no, you don't give him any mark. Next comes your T. T, now this we are coming to now signs. Initially we are talking about symptoms. T stands for tenderness in right lower quadrant, right iliac fossa at McBurney's point, straight away allot 2 points. The person has got tenderness in right iliac fossa, which is a sign, please allot him 2 points. A person has pain in periumbilical region, shifted to right iliac fossa. Now he says, when you examine, there is a tenderness in right iliac fossa, please give him 2 marks. So T is over. Now then comes R. R is, please tell me what is R? I have talked to you, I think you must be knowing all these things before. What does that R stand for? Okay. Right, you may be right. Yes. R stands for rebound tenderness. What does it stand for? It stands for rebound tenderness. Rebound tenderness means in right iliac fossa, you have palpated the patient, you are pressing like that, and patient evinces with pain. That means rebound tenderness. You have released the pressure, and inflamed appendix strikes back at the parietal peritoneum, gets pain. This is called rebound tenderness. Give him 1 point. After R, now what do we get? E. E stands for, what does it stand for? All right, think for a moment. E stands for elevated temperature, fever. Okay, E stands for elevated temperature. Patient has low grade fever, L at 1 point, 1 point. And after that, next is L, mentrals, L. L stands for what? L stands for leukocytosis, TLC count is raised. So any person with all these features, if leukocyte count, total leukocyte count is more than 10,500 cubic mm, is on the higher side. Okay, so what do you do? No, this is, I'm talking about investigations. Give him 2 marks now. Give him two marks. And lastly is S. S means shift to the left. Shift to the left means your TLC count, you have more than 75% of neutrophils. If the count of neutrophils is more than 75%, so therefore you give him 1 point. This is, so that covers mentrals. Now, if the score, you do the total scoring, if it happens to be less than 5, that means person is unlikely to have appendicitis. Please do not operate him. And you can wait and watch, give him IV fluids or antibiotics, something like that. Conservatively you manage. In person where you are suspecting acute appendicitis, don't give them anything orally because it increases the peristalsis and God forbid there is perforation, where you will be, and particularly in children, small children whom the momentum is not developed that much, where a child is likely to have peritonitis because there's nothing to seal off. Momentum is too short. Similarly, the story about elderly also. Now, if the Alvarado score, mentrals, is less than 5, you can wait and watch. But if the score is more than, say, you can say that 5 to 6, you don't know, but you can have some kind of a guess. Likely, I don't know, but probably you're not very sure. Few points are missing. Okay. Then comes your 7 to 8. If your Alvarado score is somewhere 7 to 8, yeah, there is a possibility. Probably, yes, of course, there are strong for. You can discuss among yourself, your colleagues, always generally. And I was head of the department of surgery in a medical college. I believed in consensus. Even we start with the interns and JRs, residents, senior residents, things like that. It's always very, very good. I always believe people used to tell me, sit in chamber, why are you seeing the patients? No, you have to have watch on the youngsters. How are they going to learn? And many patients will go back without being examined and nothing going. I'll sit with my youngsters and should be available. If my youngster is available in ICU and emergency, I too will be available in emergency. I'm not that kind of a guy who will sit in an office and keep on getting reports, come in the morning, go back in the evening, afternoon, whatever it is, without seeing a single patient. This is what? Not done. So what I'm to say, have a consensus. When you have a consensus, sometimes it happens. The youngster is reading the books daily. We are also reading books daily almost. We were. So therefore, always is good with the patient. So what I was talking to you, that when the Alvarado score is 7 to 8, yes, there is a possibility of appendicitis. So you can exclude some kind of ureteric problem, other problems, and you may go ahead. Right? Wait and watch or something like that also is possibility. But if it is 9 to 10, it is acute appendicitis, go ahead and operate on the patient. Don't delay. If you delay a person who has got acute appendicitis and God forbid it perforates here peritonitis, and the mortality is higher. Not only that, if you have not operated, treated conservatively, a person with acute appendicitis, and this patient happens tomorrow, God forbid, he gets an attack on acute appendicitis where there is, no medical facility, no hospital nearby. Say a person is a mountaineer, he has to go to an expedition on the mountains, or is a soldier, he has to go to Siachen on high altitude area. There's Siachen on posts and pickets. I have stayed in these high altitude areas for a pretty long time. Long years, not once, but very, very long years, 3 times. And if God forbid, even if the doctor is there, surgeon is there, he has no OT, no anesthetic, nothing of that, so he gets acute appendicitis. The snow has fallen. You can't evacuate him. There's nothing all around but snow on 17,000, 18,000 feet height. And it's all clouded. Chopper won't be able to, locate us. and evacuators. So therefore, a person who has an acute appendicitis, please operate him. Tomorrow, if it resolves, well and good. If there is no recurrence of acute appendicitis, okay. But a person might land up in Antarctica on an expedition. You have to go, and nobody is going to listen to you. That you said I had an attack of acute appendicitis. No, nobody's bothered. Once you are detailed for that, you're jolly well. You go out to that place. Nobody is going to listen to you. We do not know in what kind of situation in future any person lands. So therefore, any kind of a problem arises, please correct it at that moment. This is our duty. That is why we are living. That is why we see moving around. God has given us nature, has given us this life. What for? To do our job in time. And those who don't do it, I I don't know what should I say. Okay. Now before that, once the person is put in anesthesia after is duly resuscitated and you palpate there is a lump. Now you have scored 10. Alvarado score tells you that 10 points, you go ahead with surgery. Patient has got guarding also, and enthusiastic surgeons, even if there's a lump, will go ahead. I used to do that. But God had been very kind to me and always come out scot-free. So therefore, if you find you palpated lump, do not operate upon a person, because lump means inflamed appendix is surrounded by the omentum, the small intestine, they are matted together. The cecum is friable, and you touch it, you explore, and you are fiddled around with the cecum. I've seen a guy, I told him not operate. He persisted and said, then go ahead. Anyway, sometimes youngsters don't listen to you. One should give free hand, whatever. And the same thing happens. He enjoyed the cecum. And once there is cecal perforation, my dear friends, I have seen the cases. It takes months and months for the fistula to heal. All right, then you put in catheters, Foley's catheter, this catheter, that catheter into the cecum and exteriorizes things and takes long time for healing. So if there is an appendicular lump, my advice to you, wait and watch. It's called Ochsner-Sherin regime. Ochsner-Sherin regime. Ochsner-Sherin regime. Give him IV fluids, give him antibiotics, and wait for the best. The pain resolves, the pain comes down, the tenderness regresses, bowel sounds appear, and patient is better, fever settles, pulse settles. Continue with the conservative treatment. But if besides conservative treatment, Ochsner-Sherin regime with IV fluids, antibiotics, you find the pain is increasing, the area of tenderness is increasing, and patient has developed appendicitis, of course, we do certain investigation like ultrasound, and you suspect the temperature is rising, elevated temperature. Now, instead of having low-grade fever of classical, typical acute appendicitis, now temperature under 4, under 5, that means there is a pus inside, drain it. Don't fiddle around. All right, the appendix is good morning type of appendix and lying before you, gangrenous, all right. Okay, the story is different, but otherwise, if there's a pus in the peritoneal cavity, drain it. And if you have succeeded in managing the patient by conservative treatment, Ochsner-Sherin regime, wait for 4 to 6 months and thereafter do the appendicectomy, interval appendicectomy. Have you done it? Follow the rules of the game. And sometimes you find difficult now on exploration. When you're doing interval appendicectomy, you find the appendix only this much. It has got atrophic, and then you said, why the hell, what is this kind of small appendix? And at times it may get atrophic totally. But however, I can tell you, when you are doing interval appendicectomy, it can challenge your surgical skill to the extent that may take a couple of hours even to remove that appendix. Your mind is called inside, a lot of additions in cecum, intestine. You can't do the head and tail of the location of this thing. You're in a catch-22 situation. A very, very difficult thing. Anyway, so therefore these were the things which I wanted to tell you. Now let us see. Investigations. What are the investigations? I've already told you what are the investigations. It's not normal, like CBC and things like that. You should do CBC number 1. You should do urea and creatinine. Yes, of course. You can do C-reactive protein also. C-reactive protein that shows there's some kind of infection inside. But all these investigations are quite normal. But however, will X-ray help you in acute appendicitis? No, it will not help you. It will only help you you will find a localized gas shadow, number one. And X-ray will definitely tell you something about if the patient is prepared. Generally, when a person is having acute appendicitis, he's not taking anything. He's on IV fluids, the gut, you expect it to be clear. So you may be able to detect some kind of equilibrium, possibly a radiopaque shadow in the ureter, number one. And if there is any complications, say perforated duodenal ulcer or acute cholecystitis or any perforation of small intestine, so in erect posture, you'll find gas under both the domes of the diaphragm. That is the help the X-ray can give you. But outrightly, if you say that X-ray is sensitive or specific for acute appendicitis, no. Ultrasound, yes. Ultrasound has got some limitation, but because ultrasound is not a very good investigation. A person who's fatty and obese, you find lots of people in our country these days who are good eaters, and the lifestyle has changed totally in some categories of people. So it's difficult. But I have seen few of the radiologists, ultrasoundologists, and in one of the youngster I had come across, his rate of correct true sensitivity or specificity, the true positivity and the negativity, true negative, I am telling you, was 100%. And I used to depend upon it. If he says appendicitis, it always turned out to be appendicitis. So in appendicitis, if you're able to see it, it becomes incompressible, and the diameter of the lumen of appendix becomes more than 6 mm. You may find fluid collection in the right iliac fossa, or you will find some kind of target sign, which is, when we discuss interoception, I'll tell you all those things anyway. So ultrasound is an investigation, no doubt about it. In our times, old times, we have nothing with us. We have an operating even without X, and straight away in clinical features, and these are the signs, and we operate. Then comes your CECT, contrast enhanced CT. You remember that one hand person is having acute appendicitis, he might have perforation. So contrast enhanced CT. Once you are giving contrast enhanced CT, you are exhibiting a person to radiation, intense radiation. And a small child, 2 years old child, would you like to expose him to CT? He's looking forward to life. He's coming up like a tender bud in this. And we are exposing to CT. CT is a very good investigation to diagnose appendix, undoubtedly. But kindly take care, balance, think about it, have consultation amongst yourself. Not make solo decision like that. You are head of the department. Your knowledge is no doubt fantastic. People ask you so many things, but there's absolutely no harm in talking. Get on together during the ward rounds and things like that. Your professor is there with you, your assistant, associate, and senior resident interns, whole lot of you, the whole team is. So discuss frankly, you have to teach them also. Disseminate our impression, images, and experience. It should descend down. Until we call it a day, kick the bucket. Till the day 80 or 90 you are working, please go ahead, keep on working in a team spirit together. The solo decisions and things like that. Anyway, I'll come back to that story. So therefore, listen to the youngsters. Yes, give them a free hand, mind. Yes, what is your opinion? What is your opinion about exposing a 9-year-old boy to CT? And all these features are there. Everybody will come with some of the very glorious solution for yourself. Really, I'm telling you. So CECT is not the very best investigation to diagnose acute appendicitis. Then, of course, other investigation, never forget to do this thing during routine examination. That will also help you to some extent. And your treatment is strictly based on history, clinical examination, investigation, and then go ahead. Okay. Now coming back to what can happen to a patient if you don't operate. Appendix, no, it will get resolved also in many of the cases, but it may perforate and cause acute appendicitis. This thing, peritonitis. And sometimes there may be some tumor inside, carcinoid tumor of the appendix. Carcinoid tumor can cause appendicitis, and you have delayed it. Those are the problems: peritonitis and perforation, gangrene of the appendix. Okay, and mortality and things like that. So we have to operate on a person. So before you operate, person should be resuscitated. And resuscitation means you hydrate the patient, give him IV fluids, give him reasonable antibiotics. The two methods. One is the open method, open appendicectomy, where you give incision. Now you be very strict about your incision. You follow that. Incision is always given at McBurney's point. At McBurney's point, at right angles to a line which is drawn from the umbilicus to the anterior superior iliac spine. Give a small incision, 4 to 5 centimeters will do. Give a skin incision, external oblique epidermis is incised. Then you split the muscles, internal oblique and transverse abdominis. Then pick up the peritoneum, incised, increase the incision on the peritoneum, parietal peritoneum, and then locate the appendix. The best thing to locate appendix is your finger. See, where you, by and large, most of the cases, you'll be able to feel the base of the appendix all the way to the appendix and deliver it. If you are unable to deliver, nothing now. Now cool down. Now go slow. Once you located the appendix, things are in your hand. Nothing. Don't be in a hurry. Anesthetic should be good on giving a good relaxation, good general anesthesia. It should not have seen many cases. You are operating and the patient is moving around. The muscles are guarded, not relaxed. He is not given the muscle relaxer. Now you keep in. If it's a junior one, you can at least. If it's a senior, you have to say, sir, a little bit, if you don't mind, sir, the patient is moving and not relaxed. Good relaxation is very, very important. And anesthesis, your good friend. If you're not friendly to anesthetist, while we are operating on these kind of personal consideration, opinion, biases, prejudices should never come up. There's a patient who's helpless, is lying on the table. He's at the mercy of surgeon anesthetist. Anesthetist should be great. Anesthetist should be the greatest philosopher, like Socrates and Aristotle, and who should not have a feeling of some kind of, we are all human beings, having some kind of tiff with surgeon or something else. You forget about all this consideration. The